Welcome everybody to our fourth webinar in the series on cirrhosis care, practical tips that you can use in your practice. Thank you for coming back for this excellent session. And my name is Punita Tandon. I'm Associate Professor of Medicine and Co-Director of the Cirrhosis Care Clinic and Transplant Hepatologist at the University of Alberta in Edmonton. I'm also Medical Director for the Office of Lifelong Learning and the Physician Learning Program. The Office of Lifelong Learning is committed to providing the latest information, advice, and resources related to cirrhosis care for physicians and other healthcare providers. Just before we begin, I would like to acknowledge that we are on traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. I am very pleased to introduce Dr. Jennifer Lai to share with us her presentation on practical tips in frailty diagnosis and treatment in cirrhosis. And Dr. Lai is a dear friend and a transplant hepatologist who specializes in caring for patients with chronic viral hepatitis, autoimmune disorders, and cirrhosis, particularly those awaiting liver transplant. Her academic mission is to improve the lives of patients with end-stage liver disease through the application of core principles of geriatrics into the care of patients with cirrhosis. So examples of these principles are what she's going to talk to us today about, include assessing and reversing physical frailty, reducing polypharmacy, and integrating palliative care into transplant. She's a principal investigator of the NIH-funded Functional Assessment in Liver Transplantation, or the FrAILT study, which is actively enrolling patients with end-stage liver disease awaiting transplant for assessments of frailty both before and after transplant. So with that, Jen, thank you so much for joining us and looking forward to your talk.
Great. Thank you so much for the invitation to be here, Punita. I wouldn't miss any event organized by you because they are always executed to perfection. So thank you so much. So this is my favorite topic, and it's one that has been so inspired by Punita herself. And so feel free to chime in. But thank you so much for this opportunity. And here are my financial conflicts of interest, all of which have terminated as of over a year ago. So I am sure that every single one of us caring for patients with cirrhosis can think of at least one patient in whom frailty was a direct contributor, if not the main contributor to their death. You know, I can think of so many patients in whom I thought, if only he weren't so frail, maybe that patient would have survived his episode of SBP, or spontaneous bacterial peritonitis. If only she hadn't been so frail, we could have banded her varices and she could have made it to transplant, for example. So I know that we've all had this personal experience with our patients with cirrhosis. And the data over the last 10 years have really supported this clinical intuition. Frailty is strongly associated with adverse outcomes in patients with cirrhosis. It is associated with a twofold increased risk of waitlist mortality. It is associated with a greater risk of hospitalizations and mortality after hospitalization. It's associated with poor quality of life and subsequent disability, as well as a higher risk of mortality and poor functional recovery after liver transplantation. And if a picture were worth 1,000 words, this is how I would draw it. Frailty is essentially a patient's physiologic reserve. And I want you to think of two patients, all of whom are equal, but they're, same gender, same age, same MELD score, same amount of ascites and encephalopathy, and they're only different by their amount of physiologic reserve. One patient is not frail, as shown in the dotted line, and the second patient is frail, and both of whom are exposed to the same acute stressor. Let's think of it as maybe a spontaneous bacterial peritonitis, which is so common in our patients with cirrhosis. The patient who is not frail, in other words, who has some degree of physiologic reserve, will experience a transient decline in their physiologic reserve in response to the acute stressor. But once we start the antibiotics and remove that acute stressor, this patient will be able to regain some of their physiologic reserve and really get out of the hospital without without really any other complications, and be on his or her road to full recovery. The frail patient who is already starting with so little physiologic reserve will experience the same transient decline in their physiologic reserve, but then be propelled into and below this threshold of adverse outcomes. And this is the patient who then experiences an episode of hospital acquired pneumonia during their hospitalization, or a C. diff infection that'll set them back again, or will get acute kidney injury, and then that will lead to chronic kidney disease needing hemodialysis. And it'll just be one setback after another because they just don't have enough gas in the tank to really get to recover from the single stressor and get out of the hospital. Frailty is actually a construct that was originally defined in the field of geriatrics and is most commonly defined as a distinct biologic syndrome of decreasing physiologic reserve and increasing vulnerability to health stressors. In the geriatric population, there are multiple factors that contribute to the cycle of frailty, including the actual process of chronologic aging, comorbid factors, and progressive immobility. But in patients with cirrhosis, there are a whole host of other factors that contribute to frailty and contribute and worsen and accelerate this cycle, such as portal hypertension, ascites, hepatic synthetic dysfunction, chronic inflammation, malnutrition, sarcopenia, catabolism. All of these contribute and accelerate this cycle of frailty. And so I would propose a modified definition of frailty for consideration in patients with cirrhosis as the phenotypic presentation of the intersection between nutritional status, muscle function, and muscle mass. And the reason that this intersection and this definition is important for the purposes of this talk today is that it serves as a roadmap for reversal, what I will call prehabilitation for the purposes of this talk. And we can use these three targets to target frailty ultimately to reduce death, improve function, and improve quality of life. So let's begin. The objective of this talk is to allow you to acquire pragmatic skills to prehabilitate your patient with cirrhosis that you can take to your practice and implement in your practice today. Prehabilitation is formally defined as the process of enhancing functional capacity prior to surgery to improve tolerance for the upcoming physiologic stressor. If we go back to the original figure of frailty and replace the acute stressor with surgery, which is where prehabilitation, or this term prehabilitation, originated, prehabilitation is essentially bringing up or giving the patient a little more physiologic reserve in preparation for surgery. But in patients with cirrhosis who experience such dynamic clinical courses, it could be any acute stressor. It doesn't have to be surgery itself. I want to frame this talk in terms of a three-step approach to prehabilitation for real-life clinical practice. Step one is to measure it. Step two is to focus on muscle health. And step three is to offer motivation. Let's start with step one. We actually all measure frailty all the time with a universal tool, the eyeball test. And there's no doubt the eyeball test in our clinical judgment really serves us very well in many cases. We should also acknowledge its limitations. It is subjective. It is variably applied from one patient to another. And it does not offer a lot of granularity. And therefore, we have limited ability to follow patients longitudinally to see if they're worsening over time or to see if they have responded to our interventions. I'm going to propose to you a 4-part frailty toolkit. This is actually one that was selected, or these tools were selected by a panel of experts within the American Society of Transplantation. And I'm going to go through each of these 4 tools with you today. The first Frailty tool for your toolkit is the Karnofsky Performance Status. This is a very simple scale that is assessed by the clinical provider or by the patient, him or herself, on a scale of 100 to 10. And they just describe really what their performance status is. 100 is basically, I'm feeling totally normal, and my condition of cirrhosis is not affecting my ability to perform and do anything that I want to do. You'll note actually that, let's go down to 70, for example. At 70, the patient is able to care for self, but unable to do normal activities. And then at 40, the patient is disabled, requires special assistance. Cut points have been established in patients with cirrhosis with 80 or above and 40 below, really representing high, intermediate, and low performance status, just for the purposes of ease of use in clinical practice. And how a patient scores on this Karnofsky Performance Status Scale is strongly predictive of outcomes, including 3-month mortality after hospitalization, mortality after liver transplantation, and waitlist mortality in children. The second tool for the Frailty Toolkit is the Activities of Daily Living Scale. You might be familiar with this one. It's the ADLs. It's assessed by the patient or the caregiver. And the ADLs can broadly be thought of as the activities that one needs to function at a very basic level in one's home. This is in contrast to the instrumental activities of daily living, which are the IADLs, which are the activities that one needs to live within a community. So really to get out of the house. And the ADLs are eating, bathing, dressing, transferring, toileting, or walking or moving around. And the ADLs in patients with cirrhosis have been shown to predict 90-day mortality after hospitalization and predict overall mortality on the wait list. The third tool I want to talk to you about today for the Frailty Toolkit is the 6-minute walk test. The 6-minute walk test is simply the distance walked in 6 minutes. It's a super simple tool, and you can actually just set up markers. Of course, nobody's going to have huge hallways to walk forever, but you can measure out, for example, 10 meters in a hallway, and the patient can just walk back and forth across 6 minutes in a hallway. You can just tape it out, and then you just record that distance. And the distance walked in 6 minutes predicts waitlist mortality and is correlated with quality of life post-transplant. Now, what's so interesting about the 6-minute walk test is it sounds very, very basic, and it sounds like it wouldn't discriminate patients' risk of death at all. But what oftentimes happens is that patients will start off really fast, and then for the first 1 minute or 2 minutes, they're going to go super, super fast, and then they tire out. And so it really is those last it's the minutes 3, 4, and 5 that make all the difference, because it is a test of endurance. So it's a really simple and fantastic way to test a patient's cardiovascular reserve. The last tool that I'm going to tell you about in the Frailty Toolkit is the Liver Frailty Index, which was developed by our team at UCSF and can be calculated on the website liverfrailtyindex.ucsf.edu for free. And it consists of 3 performance-based tests: grip strength, which can be measured using a hand dynamometer; chair stand, which is the time that it takes to stand up and sit down from a chair 5 times without using one's arms; and then balance testing, which is balance for 10 seconds each in 3 different positions: side by side, semi-tandem, and tandem. This Liver Frailty Index has been found to be strongly associated with adverse outcomes in patients with cirrhosis. And in fact, we have demonstrated that frailty essentially is equivalent to 9 MELD sodium points of mortality risk. So think of your average patient with a MELD sodium score of, let's say, 15, for example, sitting in clinic. Well, their risk of death is truly as if they were frail, their risk of death is actually as if it were a 24. So, 15, 24, that's a really different patient sitting in front of you. So frailty really does add mortality risk prediction above MELD score alone. The Liver Frailty Index also has been shown to enhance clinical prediction of death, is associated with current and subsequent patient-reported disability, predicts death after liver transplantation, and is the single predictor of functional robustness after liver transplantation. And so those are the tools that you can take to your clinical practice to measure frailty in your patients with cirrhosis today. So, what can we start to do about it? We can start focusing on improving muscle health. And I just want to remind you of the modified definition of frailty for patients with cirrhosis as that intersection between nutritional status, muscle mass, and muscle function. And we can start targeting these three areas in order to improve a patient's physical function and improve frailty. Let's start with nutrition. So, general recommendations for nutritional intake and for patients with cirrhosis have been established by multiple societies. This one is the one from the European Association for the Study of Liver Diseases, and they recommend an energy intake. A daily energy intake of at least 35 kilocalories per kilogram of body weight per day, and a recommended daily protein intake of 1.2 to 1.5 grams per kilogram of body weight. I think it's really important to be very specific with patients because yes, we can tell them, okay, 35 kilocalories per kilogram of body weight per day, but then they have to sit around and start calculating their total energy intake and protein intake. And we basically just created one more barrier for them to really achieve their goals. And so I actually sit down with patients and I kind of eyeball I eyeball their weight. And so I kind of know how many kilocalories a 60 kilogram person should take in, 75 kilogram, 95, and 110, just general ideas. And you can see here that a 60 kilogram person should be taking in about 2,100 to 2,400 kilocalories per day. And a patient who's 100 kilograms should be taking in about 4,000 kilocalories per day. And then here's the recommended protein intake, somewhere between 70 grams for a smaller person and in the low 100s for a larger person. Now, of course, I'm sure some of you looked at this number, 4,000 kilocalories per day, which seems quite a lot for somebody who is already meeting thresholds for obesity. And so actually there have been recommendations for modifications of this daily energy intake for individuals who meet criteria by body mass index for obesity and morbid obesity with a lower threshold of 25 to 35 kilocalories per kilogram per day for individuals with a body mass index between 30 and 40, and then a even lower calorie threshold of 20 to 25 kilocalories per kilogram of body weight per day for someone with a body mass index of greater than 40. Now, I take it even one step further because you can definitely tell a patient, okay, you need to take in 100 grams of protein per day, but then when they sit down in front of their plate, they don't necessarily know how much protein is in each serving of food. So I give them general ballpark amounts of protein. I say a serving of chicken is about 35 grams of protein. A serving of salmon is about the same. One egg has 6 grams of protein. One serving of peanuts is 12 grams. And then one more step is what is a serving? So, for another ballpark way to estimate a serving size, I like to use the hand guide for serving sizes, where a piece of meat, an animal protein, is just the palm. So, here's a serving of chicken. So I say a serving of chicken, a palm size of chicken is about 35 grams. So if you really wanted to know, you need about 3 palmfuls of chicken a day. For carbohydrates, for example, if you want to do a serving of rice, you can do a handful of rice. When it comes to fats or peanut butter or cheese, a thumbful is a good serving size. And then for butter or oils, just kind of the fingertip is a good size. So this is just ballpark serving sizes because I don't think it's realistic to ask our patients to be, measuring out all of their samples all the time and weighing everything that they eat. Now, the timing of when they take in their food is just as important as how much food they're taking in. And this is the foundation for a recommendation of the late evening snack or nocturnal feeding. Patients with cirrhosis have decreased ability to make glucose or decreased gluconeogenesis, leading to increased breakdown of skeletal muscle to meet amino acid needs that ultimately leads to the frequent protein energy malnutrition that we see in our patients. In fact, a very old study has shown that the metabolic profile of a patient with cirrhosis after an overnight fast is equivalent to the metabolic profile of a healthy person after 3 days of starvation. So think about it. Every single morning that our patients with cirrhosis are waking up from sleep, it's as if they were a healthy person who had been starving for the last 72 hours. So it's pretty remarkable. And so this is the idea behind breaking the fast. So give a snack before bedtime to break the fast. Or if a patient is a late night eater for dinner, then actually when they wake up, break the fast with a very early breakfast. The optimal composition of the late evening snack has actually not been well defined. It can be about 200, 210 kilocalories. And many things have been studied: glucose solution, rice ball, regular food, a supplemental shake, branched chain amino acid enriched supplement, and they've all shown to be effective. Here's some considerations to get specific with your patients. I was using this in clinic today. A cup of Greek yogurt plus a handful of nuts would be a great option for a late evening snack, or 2 slices of toast with low salt peanut butter is another option. There is strong randomized clinical trial evidence to support the nocturnal feeding in improving total body protein in patients with cirrhosis. This was an RCT of about 50 patients who were randomized to the daytime feeding arm and 50 patients who were randomized to a nighttime feeding arm for 12 months. And as you can see, the total body protein in the patients in the nighttime feeding arm improves significantly at 3 months, 6 months, and 12 months as compared to those in the daytime feeding arm. So what's so remarkable is there was nothing different in these patients in terms of the total amount of calories they took in. It was simply that the nighttime feeding arm took in a supplement from 9 p.m. to 7 a.m. instead of during the daytime. And what is even more remarkable is that the supplement they took in was just 2 cans of an over-the-counter supplemental shake. So this was not some special nutritionist designed elemental formula that was super special and formulated in a laboratory. No, you can actually recommend this to your patients right now. Tell them to go out and get some supplemental shakes, and they can drink 2 of them over the course of the evening to significantly improve their lean body mass. Let's move on past nutritional intake and talk about exercise. Exercise is activity requiring physical effort carried out especially to sustain or improve health and fitness. I bring up this definition because when I talk to my patients about exercise, the first thing they tell me is they exercise. And I ask them, well, what do you do? And they say, oh, I walked my dog around the block. And walking the dog around the block is a good foundation. There is no doubt, and I don't want to discourage that at all, but I certainly have a dog, and I'm walking my dog on my iPhone, and it certainly is not requiring a lot of physical effort, and it's certainly not carried out especially to sustain or improve health and fitness. So I think it's really important to impress upon our patients that exercise is a lot more than simply the activity that we're integrating in our daily lives. If we really want to get our patients to be doing the kind of lifestyle modifications that we need them to reduce their risk of death. So I would recommend the FIT recommendations for exercise. FIT stands for frequency, intensity, time, and type. That's the kind of specific recommendations that we need to make to our patients. So in terms of type of exercise. There are two types of exercise that patients should engage in: aerobic activity at 3 to 5 days per week, 150 minutes total per week, and at an intensity of 5 to 6 out of 10. Now, in this sort of intensity, this 5 to 6, is hard to gauge because it's a little bit relative, but I like to recommend the talk test to guide intensity. So they should be short of breath, but they should still be able to walk. The other type of exercise to recommend is resistance training. Patients should engage in over 2 days, at least 2 days of resistance training per week. They can alternate upper body with lower body days, and you can recommend the rep test to guide intensity, which is to be able to do 2 to 3 sets of 10 to 15 repetitions each. That's the kind of not too hard, not too much resistance. So they should be really getting to 10 or 15. That's kind of a low medium resistance. I like to do exercises in clinic with my patients. And it helps me after sitting through my 15th patient of the day to do 10 chair stands with them. So some exercises to think of doing with your patients is the sit to stand. I like to have them just stand up and sit down from their chair 10 times with them. Here, the person is using their arms, but if the patient's really advanced, you can get them to cross their arms over their shoulder so they're not using their arms. The sitting knee extension is great. The sitting hip flexion is really easy. And then the wall squat is a little bit more advanced, but a really nice exercise to really engage the core muscles. And then I provide patients and I send them home with exercise resources. This first one was actually developed by Dr. Tandon herself, and it's wellnesstoolbox.ca. And this is just a fantastic resource for patients with cirrhosis. And there's another arm for patients with inflammatory bowel disease to to do very specific calculations on nutritional intake, get a lot of great evidence-based recommendations on nutrition, and also has exercise videos. And then there's some more workout videos available through the National Institute on Aging, Go for Life campaign. These are great workout videos available at goforlife.nia.nih.gov in particular for older adults, but also for frail individuals. And then the last exercise program I like are for the most frail patients. It's the Otago exercise program, and it's an evidence-based fall prevention program for frail older adults, and it includes 12 strengthening exercises. And then I'm super excited and thrilled to be giving you a little teaser about what's to come. This is also a nutrition and exercise app that is almost ready for launch by Dr. Punita Tandon. It's the Heal Me exercise app, and I've gone through this app, and it is an incredible guide and resource for patients to provide general information, but also tailored information for their condition and their specific situation. And it allows them to track their exercises, track their intake, and it's really evidence-based. So I'm super excited for when this comes out, and we'll be recommending it to all of my patients. Okay. Oh, hold on. Sorry. That is the prehabilitation toolkit, and there is one therapeutic that I can offer, and that is intramuscular testosterone. Intramuscular testosterone has been studied in a double-blinded, placebo-controlled, randomized clinical trial in men with cirrhosis and low testosterone. And these injections of intramuscular testosterone were shown to improve lean muscle mass compared to placebo at 6 months and 12 months. You can see how significantly lean muscle mass improved over placebo. And importantly, you should note that lean muscle mass decreased significantly in the placebo arm, as would be expected for a patient with cirrhosis. And then you can see also that fat mass decreased in the testosterone group more at the first 6 months and then plateaued at the 12 months. And you can see in the placebo group, the amount of fat mass just increased, probably in proportion to the amount of decrease in lean mass. And so this is something that I have started to routinely check in my men with cirrhosis cirrhosis, and referring to endocrinology if their testosterone levels are low and if they do not have any contraindications to testosterone replacement therapy. Okay, so that is the focus on muscle health. And let's go to step 3, which is motivation. In order to start motivating our patients, I want to just provide you with one framework. There are many frameworks for offering or for helping motivate patients, and I'm really looking forward to hearing from our panelist a little bit later, our behavioral specialist later. But I wanted to offer the nudge behavioral therapy. This one is supported by recommendations from the United Kingdom Meeting on Exercise in Solid Organ Transplantation that put out their recommendations just a couple of years ago in 2019. Nudge behavioral theory encourages interventions that focus on changing the environment, including both social and physical aspects, in such a way to increase the probability of people performing a desired behavior without requiring those people to think very reflectively about it. So, in other words, it's kind of trying to remove all barriers to behavioral change and making it as easy as possible for people to change their behavior. This consensus panel on exercise and solid organ transplantation further recommended a toolkit for implementation of the nudge behavioral theory, which was MindSpace. MindSpace stands for 9 non-coercive mechanisms to influence behavior. Those 9 non-coercive mechanisms are messenger, incentives, norms, defaults, salience, priming, affect, commitments, and ego. In the interest of time, I'm only going to focus on the top 3, which is MIN. But I do encourage you to pull up this framework and just look and read a little bit more about all of them because they're super interesting. And I think we can all find ways in which they will apply to our clinical practice, but even our own personal practice. M stands for messenger. We are influenced by who communicates information. I think it's really easy oftentimes it has been the habit for primary care providers, for gastroenterologists, for hepatologists, to refer the nutritional recommendations, to refer exercise recommendations to another provider, to refer these recommendations to a dietitian or a physical therapist. And there's no doubt that a great nutritionist and a great physical therapist are absolutely essential partners in helping to prehabilitate a patient with cirrhosis. But it is such a strong statement to the patient when the primary hepatologist or the primary gastroenterologist or the family practitioner also spends the time to offer specific nutrition recommendations, offer the hand guide to serving sizes and calculate out protein requirements and do chair stands with them, because it sends that message to the patient that the number of chair stands you do is super important to your outcomes and as important as taking your antibiotics to prevent a spontaneous bacterial peritonitis. The I in MindSpace stands for incentives. We are easily motivated to avoid losses, favor immediate payoffs, and overweight small probabilities. So before I read about nudge theory and MindSpace, I had this tendency to say, well, don't eat too much salt, and my patients have told me, oh, these doctors have told me that too much protein will lead to hepatic encephalopathy. I'm really worried about the risks of encephalopathy. Or be careful not to fall. Don't do this kind of exercise because I don't want you to fall. But rather than emphasize the risks, we should frame it in a much more positive light. So rather than don't eat too much salt, maybe consider adding spice for palatability. Instead of the fear around protein and encephalopathy, we can set minimum and maximum protein targets for patients. So I think you should eat between 90 and 120 grams of protein per day. And then rather than emphasize the risk of falling with exercise, say, well, why don't you use a chair or the wall for balance? N in mind space stands for norms. We are strongly influenced by what others do. So it has become my habit to tell patients, as I'm talking to them about prehabilitation, that prehabilitation is standard treatment for all patients with cirrhosis. So all patients with cirrhosis need to be screened for liver cancer. All patients need a baseline endoscopy to screen for varices, and all patients need to engage in these nutrition and lifestyle behaviors. This is part of the package of taking care of a patient with cirrhosis. It is the standard treatment. And that is the three-step approach to prehabilitation for real-life clinical practice. Start with measurement of frailty in all patients, focus on improving muscle health with the prehabilitation toolkit, and don't forget that our patients need motivation and encouragement all along the way. Thank you very much.
Thank you, Jen. As usual, very practical and an excellent lecture. So I'd like to take the opportunity actually to introduce Dana. Dana is very late for Dana. She's in Halifax. So thank you, Dana, for joining us. And we forgive you if you yawn. But Dana Lee Bagley is a registered clinical psychologist. She works as a clinical health psychologist in medical, surgery, and cancer care hospital units in Halifax, Nova Scotia. She holds an assistant professor appointment in the Department of Family Medicine and cross appointments in the Departments of Surgery and Psychology and Neuroscience at Dalhousie, and an adjunct professor appointment in the Department of Industrial and Organizational Psychology at St. Mary's University. How do you do all this, Dana? She's the director for the Behavior Change Research Institute, which conducts research and training in chronic disease management. And she's an internationally recognized trainer in acceptance and commitment therapy and a certified therapist in emotion-focused therapy for couples. She has an active research program on behavior change, obesity, chronic disease, professional resiliency, and acceptance and commitment therapy. And she's won many awards and written a book called Healthy Habits Suck: How to Get Off the Couch and Live a Healthy Life, even if you don't want to. So with that, Dana, I wonder, as we're getting questions rolling in, if you wouldn't mind just giving us some thoughts, because Jen's given us some very practical tips that we can give our patients, but the challenge is always, how do you actually get people to change their behavior and buy in and do these things?
Yeah, so one thing that I think is kind of helpful to understand is a little bit, how our brains work. And this is something that I will go over with patients as well, which is, there's part of our brain kind of developed in cave people times. It's our paleo-mammalian brain. This is where the limbic system is. And it's kind of our survival brain, or like our caveman brain. This regulates things like appetite, emotions, memory, learning, automatic thoughts. So it has a pretty big impact on us. And, it functions automatically and unconsciously. So you can't turn this part on, you can't turn it off. The other relevant part of our brain is the prefrontal cortex, and this is where executive functioning happens. So this is basically controlling behavior, right? So starting behavior, stopping behavior, planning, delaying gratification. This is where willpower comes from, where self-control comes from. And unlike our caveman brain that's always working, our frontal lobe is like a battery. And so we will use up that battery of self-control as we, get through our day. And this is why, for example, binge eating is more likely to happen in the evenings compared to the mornings, because we've used up that battery of self-control and there's not much left at the end of the day. But our caveman brain's still working, very happy to offer you something that's going to make you feel good, at least in the short run, which is a great strategy if you're a cave person. You should definitely live for the moment, right? Our life expectancy was about 30. And so it's helpful when we think about these parts of our brains, because our caveman brain is always going to want what feels good right now. It does not matter if that's going to lead to like cirrhosis or heart disease or strokes. It's about what's going to work right now. And so we need to keep that in mind, that this part of our brain, wants to do what feels good now, which is almost always an unhealthy habit, especially in the environments that we live in, which are full of cues for unhealthy behaviors, right? And so we have to use that frontal lobe battery in order to make healthy choices. And it's sometimes helpful to keep in mind that, for physicians, for healthcare providers, our batteries tend to be a bit bigger than the average person. It takes a lot of self-control to get through the amount of school that physicians have to get through. So we're really the outliers. We're not like, in the normal curve of self-control, we're the outliers. Our patients are probably more in like the normal range. So the amount of self-control we have is not necessarily the amount of self-control that patients have. So some of, and I describe this to patients so they can understand why part of them wants to eat the salt, wants to eat, the fatty, sugary, salty foods, and that we really need to make sure you're charging your frontal lobe battery so that you can control your behavior. That won't change your cravings, it won't change your thoughts, it won't change your feelings, it just controls your behavior. And also, just keep in mind that in COVID-19, our caveman brains are on fire and our frontal lobe batteries are incredibly spent because we use so much of that battery just to get through a COVID day, right? It sucks up a whole bunch of batteries. So there's not a lot left for a lot of people in order to manage their behavior. But because we want, because we can control our frontal lobe, we can control behavior, we want to focus on behavioral goals, which is very much what Jennifer already described, right? So pick a behavioral goal instead of an outcome goal. So instead of, so behavior is something that someone else can see you do. So drinking, at late at night, drinking the, shake or whatever it is, the supplement, that's a behavior. Someone can see you do it. Did you enjoy doing it? Did you like it? Were you motivated to do it? That's going to be coming from your caveman brain. You can't control that part of it. So pick behaviors because they're much more under your control. You're going to feel much more successful because you can see that you've done it. Even if the outcome, our bodies do different things with things. And so we'll feel better if we're focusing on the behavior. The second one is pick a 90% goal. So pick something you're 90% sure you can do. Because if we set goals that are too big, people will inevitably fail at it. And then they just stop trying. That's just normal human behavior. We don't want to keep doing something that we're failing at. And so if you pick a goal that you're 90% sure you can do, and then work your way up from there. And of course, a 90% goal during the pandemic is going to be different than a 90% goal non-pandemic times, because again, so much of our frontal lobe goes to managing the pandemic. And then finally, this is a great point that Jennifer already made, which is a do instead goal. So there's a well-established phenomenon in psychology called the thought suppression effect, that when you try to not think about something, you think about it more. And so the example I give is don't think about pink elephants. And so, chances are you're now thinking about pink elephants more than you were before I told you not to think about them, or you're trying really hard to not think about pink elephants. And so when we set don't do goals, we're creating pink elephants, the thought suppression effect. We're going to focus more on the thing we can't have. And I remember one of my liver patients saying, yeah, I can't eat pickles anymore. And now it's all I want to eat. I never even liked pickles before they told me I couldn't eat them. And now I want them all the time. Thought suppression effect. Don't eat pickles. Don't eat pickles. Right. So think about what you're going to do instead. What are you going to do instead of, salty foods? What are you going to do instead of whatever it is, the behavior? And think about adding things instead of taking away, because then we also feel less deprived because we're focused on the things we're allowed to have versus the things we can't have. So those are my quick tips on motivating behavior change.
Yeah, those are fantastic. Thank you. And before I go to the questions, I'd encourage people to ask some questions. We've got great experts here to answer them. So Jen, your talks are always super practical, but what I often hear and what we're challenged with is, I'm too busy in clinic to do this stuff. Why should I do it? And how do I do it? So you gave us some practical tips, but can you speak to that a little bit about how you fit it in?
Great. It's a great question. It's always a struggle. But I always think about the data actually that support the association between frailty and mortality. I mean, truthfully, the frailty metrics, for example. So one of the things that I had talked to my medical assistants and our clinic staff is that grip strength is so much more strongly tied to mortality than temperature in the clinic, or O2 sat in the clinic, right? And so it does take a little bit of a frame shift. I know that you're used to taking temperature. I know you're used to taking O2 sat, but right now we've got chair stands and we've got grip strength that's strong, or Karnofsky performance status that strongly predict mortality. So that, the data have to really drive behavioral change. Second, something I just mentioned was that for me, I don't do the grip strength and the chair stance testing because we have, becomes a team effort. So our medical assistants do that now. Our transplant coordinators do that, so that shifts the burden off of me. Third, I really do use resources. So I don't know if you guys have an electronic health record and you have smart phrases that you can use. So I put in a lot of information in the smart phrases. So I don't necessarily go through every single detail, but I do say, okay, every patient with cirrhosis needs to eat a certain amount of protein. I've calculated out the amount of protein. I've put it into your after visit summary, and I offer them all of the resources, for example, the wellness toolbox, and soon your new app, Punita. And so I offer those, and then also think about shifting some of the recommendations we did used to spend time on. So, I can imagine that a lot of us are talking to our patients about screening for liver cancer. Well, the reality is, you say it once, you need screening every 6 months, and then the rest of that can probably just get sort of automated on the electronic health record or put into the after visit summary, because the patient already knows that they need to get it done every 6 months. You put in the order automatically. It probably doesn't need to take a lot of space in your clinic. So those are some of the strategies that I've used, but I welcome in the chat box anyone else who has tried other strategies, or Punita yourself, what you've used to emphasize this in clinic. Oh, you're on mute.
I am on mute. I can't believe it's been a year and I do that still. But yeah, I would echo what you've said. I guess the other challenge is that it comes up, we don't have super strong evidence that this actually changes muscle mass and frailty yet. But again, I've heard your answer to this and I think it's wonderful. So I wonder if you could speak to that as well.
Yeah, so I presented some of the data that exists that do show that protein is really important, and I didn't spend a lot of time on the exercise, but that's sort of a given. Exercise is good for patients, right? So how much data do you need to support that? So I think that's the point: is that we have so much data that demonstrate that malnutrition, that low muscle mass, that poor physical function are strongly tied to death. They're equivalent to 9 MELD points of mortality risk. And so for us to sit back as clinicians and say, well, I'm not going to do anything about it because there aren't randomized clinical trials to support that, I think is not my approach to practicing medicine. I see the data: malnutrition kills patients. And common sense is that the opposite of malnutrition is to nourish the patient, right? Common sense is the opposite of muscle failure, is to stimulate the muscle, motivate the muscle. And so for me, my own personal practices, I believe very strongly that common sense shows that these interventions will help a patient. And I welcome anyone who wants to provide data to support it, but I don't need to wait for the data before I start recommending it to my patients. I also, as somebody who does this a lot in clinic, have seen how getting control of nutrition and getting control of exercise really empowers the patient, right? Because they're working with their jaundice, they're working with their ascites, and they say, well, what can I do to make myself less yellow? What can I do to make my creatinine better? And I say, nothing. But what you can do is you can focus on these positive behaviors, such as focusing on the late evening snack, focusing on aerobic exercises, focusing on resistance exercises. So it gives, just like what Dana says, gives them a do instead, and focus on that positive behavior.
Yes, and totally that message I've heard about, a sense of control that they lack otherwise. So, and before I just go on to the couple questions in the chat box, Dana, on that line, do you assess readiness at all before doing these intervention targets, or how does that play a role?
Yeah, so I was on the transplant team in Halifax for over a decade, and part of my job was assessing suitability for transplant. We do look at adherence, and typically kind of their history of adherence, how they've done coming up to this point. The issue is that when they're at this point, they're pretty highly motivated because they're trying to avoid death, right? And so most people can do most things for a short period of time. And so they'll do lots of things before transplant to try and, and so giving them something to do. And I often would say that, like, you can't do anything about your liver functioning, but you can do something about the rest of your body. And if the rest of your body is healthier, you're going to get through the surgeries better, right? It's really post-transplant where we need that long-term sustained behavior change where people often run into trouble. And I think also in terms of like the time, the time it takes for physicians to do, which is, we teach behavior change skills to healthcare providers. And that's the number one issue is like, well, it sounds like a great idea, but I don't have time for that. One, if you're saying the same thing over and over again about like, you need to reduce your salt, you need to reduce your salt, then you might have some extra space to actually say something different this time, besides, the same thing that you've said before. And also, I think it's a great time to make use of a multidisciplinary team if you have that, right? That maybe you don't go into all the details, but you can emphasize the same things that the dietitian said, the same things that the physiotherapist said. So you can say things like, did they tell you about the POM? Did you do the 6-minute walk test, right? Just to say like, I know you know this, right? I'm giving you the same message that they are, even if you don't have time to go into it in detail. If your team members are saying similar things, you just need to mention that you know what the physiotherapist told them and you know what the dietitian told them. And so we're all on the same page here, and it's really important to do that.
Okay, yeah, no, fantastic. And that's why we're sort of excited about the app as a common language for people. Okay, so questions in the chat box. Jen, supplements. If you're using an early morning snack to break the fast, what sort of time frame are you looking at between supper and breakfast to see a benefit?
Interesting question. So I don't think the actual timing has been established, but the general recommendation is to avoid periods of more than really 4 hours, if you can. Now, of course, I hope my patients can sleep more than 4 hours. So the message is really as quickly as possible. Like, yeah, they shouldn't set an alarm to wake up at 4 hours and take in their snack, but they go to, they have something before they go to bed, and the minute they wake up, they should they should eat right away. But during the day, avoid, if they can, try to eat at least every 3 to 4 hours would be great.
Right, and our dietitian suggests to set an alarm on the phone to remind patients to do that. But,
good idea.
Okay, so still on the snack thing, what kind of supplements should cirrhosis patients take?
Yeah. So the data around late evening snack actually varies. It can be anything. I think what I've learned from the looking at the different studies is that it actually doesn't matter, and to try to get it into the 200 calorie range. But you might as well use the late evening snack or that break the fast snack as an opportunity to also get in some protein. And so I tend to recommend snacks that have protein. So I really like the cup of Greek yogurt. Greek yogurt has more protein because it's kind of the strained and concentrated version of regular yogurt. So I love the cup of Greek yogurt with chia seeds in it or nuts in it. Or the supplement, a protein shake, I think is a great option. If they like dry things, you can have them do like a protein bar. But it actually doesn't matter. Now, some people do like recommending snacks that are enriched with branch chain amino acids. There are some studies out there that have shown two randomized clinical trials that have shown benefit in terms of this combined event of decompensation and mortality with use of branch chain amino acid supplementation. And so if a patient is really, really into this and really needs like something very nutritional sounding, you could consider a branch chain amino acid enriched supplement, an enriched bar or a shake. But I think just even a protein containing food is fine.
Yeah, and I think it's just the basics. We need to do the basics, right? And get people to the goals.
I
instead of
agree.
all this fancy stuff.
I
And
try
also, to consider that like picking out a meal uses up some frontal lobe, right? To decide like how much protein is this, how much, and what time do I, so if you do it on a routine, like eat the same thing every night for your nighttime snack, that you've figured out how much, like what it looks like and how much protein it has, because that's going to reduce how much frontal lobe you need to make a good choice.
Yeah, great idea. And that's why I like those cups of Greek yogurt, because it's just like grab the cup of Greek yogurt. It's super easy. Don't use too much of that frontal lobe.
I love that analogy. Yeah. Okay, so nutrition facts for cirrhosis patients, Jen. How do they relate to the normal, compared to the normal healthy adult diet as far as protein, for example?
Oh,
Or
interesting. I study patients with cirrhosis so much that I don't actually know what is needed for a healthy person. Do you know the answer to this?
Yeah.
You must know it.
Yeah, so it's about 0.8 grams per kilo. Yeah, as opposed to the 1.2 to 1.5. So they definitely our patients need a lot more. And even in ICU, we're getting up to 2 grams per kilo. So quite a bit more because
Quite a lot
they're
more,
hypermetabolic in some cases, and they just don't utilize the protein as well. Okay. Next question, and I think obviously COVID is still on everybody's minds. What is the impact of COVID-19 on this whole situation of motivation and frailty, and how patients are responding to interventions, I guess?
It's a good question. We don't have any data yet. Do we think is this question, do you think more about the impact psychologically, or do we think it's about, can it cause decompensation, like the medical effect?
Yeah, potentially even that. It was
Yeah.
fairly general. What is the impact of COVID-19 in stable liver cirrhosis?
I mean, certainly I've seen a number of my patients with stable and compensated cirrhosis decompensate in the setting of COVID and have a spike in their liver enzymes because of the COVID related hepatitis. I've seen the transplant patients reject. So I've seen the transplant patients, have very, very severe infection, but then also reject as a result of it, of pulling off the immunosuppression. So COVID-19 is definitely impacting patients with cirrhosis. The data that was presented at our liver meeting in November definitely showed that patients with cirrhosis had at least a 3 or 4-fold increased risk of mortality as compared to someone with chronic liver disease, or chronic liver disease without cirrhosis, or without any liver disease at all. So it certainly is, cirrhosis is a huge risk factor for death.
Yeah, and psychologically, I mean, we know the pandemic itself is causing, a tremendous toll. I often kind of say, if this was World War III, and psychologically, it's like being in a war. And if it was World War III, we would get rid of all kinds of expectations and we would just focus on the war effort. And that would actually help us balance things out, because we would get rid of all kinds of expectations. But what we've done in the pandemic is we've just added the stress of the pandemic onto the stress of everyday life. And then we're somehow shocked that people aren't doing well. Like the statistics on mental health are just that it continues to decline. Anxiety rates are up, depression rates are up, suicidal thoughts and feelings are up. And so it has an enormous toll. And I think it's also about kind of setting reasonable expectations for patients about what they actually can do. Because again, people don't have a lot of frontal lobe because they're using so much of it to follow public health guidelines, to avoid people, all these things that take extra effort. And we also have the perception of threat makes our limbic system on fire, I like to say, just fully activated and doing all this thing. And that uses up some frontal lobe as well, just to try to manage that. And so staying steady is a win in a pandemic.
Totally. Yeah. Resetting expectations. Dana, where can we learn more about behavior change and talk as physicians and other practitioners in allied health? Do you have any courses or resources?
Yeah, so we do training for healthcare providers, specifically, non-psychologists, so physicians, nurses, OTs, PTs on behavior change skills, which are like empirically based skills for, improving self-management of chronic disease, really. And, our healthcare system is awesome for acute illness. It is not well designed for chronic disease. And that's, it's the sustained behavior change that really is the trouble. So if you go to my website, there are, I've written articles about COVID, and there's resources. You can contact us to find out when there's like training available as well. So yeah.
Fantastic. Okay, so I think we're at the hour, and I want to thank everybody for attending, and thank you both. You're fantastic panelists and wonderful talk, Jen. And come back next week. It's going to be amazing with Amanda Brisebois around palliative care, and it's not just end of life, and she's going to enlighten us on that. So it'll be another fantastic session. Thank you, everybody, and we'll see you guys next week.
Great. Thanks for the invitation to be here.
Okay,
Thanks for having me.
Stay safe.
Good night, Dana.
Hello, Dana in Halifax.
Hello, Denise. How are you?
Good. Thank you so much. That was great.
Yeah, thanks.
I
so
really
much for
enjoyed it.
having us.
I wish I was sorry I was a little bit late coming from clinic, but I wanted to like plug your book. Your book is so awesome.
Thank you. That's very kind of you.
Oh dear. Yeah, how are you doing?
Yeah, good. Thanks. Well, I mean, as good as one could be in a pandemic. Yeah. So it'd be lovely.
I sent you an email. We'll connect, and I so appreciate you doing this like in the middle of the night.
Yeah, definitely time for me to go to bed. Not much frontal lobe left.
Exactly. How's your son doing?
Good. We're allowed to play hockey here, so he's happy.
Oh, good.
Yeah.
Good.
Yeah.
All right. Well, let's connect soon for sure.
Yeah,
Hey?
that sounds great. Nice to see you virtually.
You were fantastic, Dana. Thank you. I just want to pop
thanks
up
for
to
having
say
us.
that. Yeah, super
Thanks for having me.
practical.
Right. Yeah, I like to say I have learned how to speak physician. You got to say it in 30 seconds or less, and it has to be only what they need, nothing more.
Nothing more. Perfect. Yeah, you got us. That's right.
Oh my God. Well, I'll catch up with you tomorrow, P.
Yes, I will see you tomorrow, and good night, everybody.
Good night.
Yeah,
Thank
good night.
You.
You guys have a good one.
Bye.
Thank you.
Bye-bye.
Bye.
Thanks for joining, Dana.
Thank you.
Bye, Mel.
Bye. Look at this one. Just a second. What a black hole.